plus involvement of oculomotor nerve nucleus. What will happen if there is injury of oculomotor nerve nucleus? Can any one of you tell me?
Downward and outward gaze.
Yes, downward and outward eye if there's damage to the oculomotor nerve. So if someone presents to you with feature of Parkinson disease such as stiff and freezed posture, rigidity, and tendency of falling backwards, shuffling and freezing gait, plus restricted downward gaze, then the diagnosis will be progressive supranuclear palsy. So a person with the features of Parkinson disease such as frontal rigidity and a tendency to fall backward and restricted downward gaze, then the diagnosis will be progressive supranuclear palsy or Parkinson plus syndrome. Progressive supranuclear palsy is also known as Parkinson plus disorder. Parkinson plus feature of oculomotor nerve nucleus injury as well as injury to the other areas of brain, which can result in affecting the gait, balance, speech, swallowing, etc. So a person with features of Parkinson plus restricted downward gaze, the diagnosis will be progressive supranuclear palsy. Now some types of tremors. Tremor can be resting tremors, they can be postural tremors, or they can be action tremors. And the fourth type is tremors can be psychogenic as well. So what are resting tremors? The tremors which are present at rest. Resting tremors is a classic feature of Parkinson disease. So resting tremor is present in the Parkinson disease along with other signs and symptoms of Parkinson disease. So if a person is having a tremor at rest plus other features of Parkinson disease, then the diagnosis of Parkinson disease will be made. The second type of tremor is postural tremors. Postural tremors are more obvious in a specific posture. For example, when holding out, when skeletal muscle is holding in a position against gravity. For example, if you ask the patient to extend his arms and hold in the mid-air, so basically you can say that postural tremors are obvious in a specific posture, such as holding out hands in mid-air against the gravity. The example of postural tremors include essential tremors, side effect of beta agonists such as salbutamol. They can also cause postural tremors, and alcohol withdrawal can also cause postural tremors. Plus, thyrotoxicosis can cause postural tremor as well, and chronic liver disease can also cause postural tremors. So, for Plab 1, resting tremors are caused by Parkinson disease. Postural tremors, which are evident in a specific posture, such as holding out hand in midair against gravity. Example of postural tremors or the things which can cause postural tremors. Essential tremor, which is an autosomal dominant condition, can result in postural tremors. Salbutamol has a side effect of postural tremor, and alcohol withdrawal What? Someone want to ask any question? The third type of tremor is action tremor. Action tremor or intentional tremor, they are present in the cerebellar disease and multiple sclerosis. So action tremor or intentional tremor is present in the cerebellar disease. So along with action tremor, the sign and symptoms of other sign and symptoms of cerebellar disease such as nystagmus, ataxia, dysdiadochokinesia will also be present. Thyrotoxicosis CLD can also cause postal tremors. Now the fourth type of tremor is psychogenic tremor. The psychogenic tremors are psychogenic, mean there is a psychological association or they are functional tremors. There is no organic cause of these type of tremors.
So the
Psychogenic
thyrotoxicosis tremor, is it an action tremor or is a postal tremor?
postal tremor are also action tremor as well, because postal tremor are evident when you performing a certain action. They are not present at rest. So you can say that postal tremors can also be action tremors as well.
Okay.
So the fourth type of tremor is psychogenic tremor, which is abruptly in onset and there is spontaneous remission. And the tremor disappear when the patient is distracted. Remember that only resting tremors of Parkinson disease is present at rest. All other tremors are not present at rest, such as essential tremor, psychogenic tremor, and action tremor or intentional tremor. They all are absent at rest. How you are going to differentiate between them? Remember that psychogenic tremor and essential tremor, how they can be differentiated. Essential tremor does not disappear when the patient is distracted. On the other hand, psychogenic tremor disappears when the patient is distracted. Why it disappears? Because the origin of psychogenic tremor is basically a psychological reason. So when the patient is distracted, basically his mind is focused on something else. So that's why psychogenic tremor disappear when the patient is distracted. While on the other hand, essential tremor is absent at rest, but it does not disappear when the patient is distracted. And also, essential tremor improves with the use of alcohol. Essential tremor basically is due to decreased activity of GABAergic neurons in the brain, and alcohol increase the activity of GABAergic neurons, which are inhibitory neurons. So that's why essential tremor improves with alcohol. So these were the four types of tremors which can be asked in the Plab 1 exam. Resting tremor, present at rest, along with feature of Parkinson disease. Action tremor are present during and in the action, plus with feature of cerebellar disease. Then it will make diagnosis of cerebellar disease. And the tremor which is absent at rest and is evident in a specific position, such as holding out hand against gravity in midair. They can be postal tremors or psychogenic tremors. How to differentiate between essential tremor and psychogenic tremor? Essential tremor, does not disappear when the patient is distracted, while psychogenic tremor are disappear when the patient is distracted because their origin is psychogenic. So if the patient attention is diverted or the patient mind is focused on something else, then psychogenic tremor disappear. Another differentiating point is that essential tremor improves with alcohol use. So the types of tremors and how to identify or differentiate between them is clear to everyone. Is there any question anyone want to ask? So a tremor that improves with the use of alcohol is essential tremor. No question, guys.
So I have a question. It's like,
Yes.
this postural tremors, the essential tremor and action tremor, they are the types of postural tremors, or postural tremor is separate.
Essential tremor is an example of essential tremor is a condition or an example of a postural tremor.
Right. And action tremor, is it same as like, or is it just related to cerebellar disease? The action tremor, which
Action
is
tremor is related
intent.
to cerebellar disease, but you can say that essential tremor is also an action tremor.
Essential tremor is an action tremor. So it's giving me a little bit confusion.
For in simple words, you can say that there is an overlap between postal tremor and action tremor.
Right.
Postal tremors are action tremors as well because they are evident in performing certain action as well as in a specific posture.
Right.
So you can say that postal tremors are action tremor as well when they become severe.
But
Is that right?
it's not necessarily that they will be related to some cerebellar disease.
Yes, postal tremor are not present in cerebellar disease. In cerebellar disease, the type of tremor that is present is intentional tremor or action tremor. Postal tremors are present in thyroid disease or thyrotoxicosis.
Mm-hmm.
Normally, if you ask a patient of thyrotoxicosis to hold out his arms in midair against gravity, then a tremor will be evident.
Right.
That will be called postal tremors because the tremor is evident in a specific posture. Similarly, in case of alcohol withdrawal or in case of liver disease, in liver disease, there is a tremor which is called flapping tremor. If you ask the patient to hold out his arm in midair against gravity and you flex his wrist, then the tremor will be evident.
Right.
But the tremors that are present in thyrotoxicosis or liver disease or salbutamol or alcohol withdrawal, they are only evident in some specific postures and uh, not evident while performing any action when they are mild.
Right.
So there is a slight bit of difference between these two.
Mm-hmm.
You just need to remember that.
Fine. Thank you.
Is it clear?
Yes, it is clear. Thank you.
So again, resting tremor, Parkinson disease, postal tremor. Example of condition which can have postal tremor is essential tremor, which is an autosomal dominant genetic condition. which can has postural tremors. The most common cause of postural tremor is essential tremor. Salbutamol can also cause postural tremor. Alcohol withdrawal can also cause postural tremor. Thyrotoxicosis, CLD, can also cause postural tremor. Action tremor is present in important disease such as cerebellar disease or multiple sclerosis. And psychogenic tremor are due to psychological reasons, and they disappear when the patient is distracted. This is an important diagnosing point. A tremor that improves with alcohol. Which tremor is that one? Anyone?
Action tremor.
Essential tremor.
Essential tremor, not action tremor. Essential tremor is a condition.
Yeah.
It
Essential.
is a disease, or essential tremor is the only tremor that improves with alcohol. So we were discussing Parkinson plus or progressive supranuclear palsy. And what is the diagnostic point for progressive supranuclear palsy or Parkinson plus? Down and out eye or restricted downward gaze, along with signs and symptoms of Parkinson disease, such as rigidity, falling backward, shuffling gait, etc. Now, some points about delirium. The dementia and its causes are finished. So, dementia was a chronic condition of memory and behavioral problems, while delirium is an acute problem that occurs suddenly over over a period of days and not months or weeks. So delirium is basically a confused mental state that occurs suddenly. In old age patient, confused mental state that occurs suddenly is called delirium. And the causes of delirium, they are important to remember. The causes of dementia has already been discussed, such as Alzheimer's disease, frontotemporal dementia, Lewy body dementia, normal pressure hydrocephalus, Shy-Drager syndrome, progressive supranuclear palsy. All of them can cause dementia. It is also important to remember the causes of delirium. The most important cause of delirium in old age patient is infections. UTI is the most common infection that can cause delirium in older adults. Also, upper respiratory tract infections such as pneumonia can also cause delirium. Intoxication, dehydration, metabolic derangements such as hyponatremia, hypokalemia can also cause delirium in older adults, and drugs as well, such as benzodiazepines, can result in delirium. So the three important causes that you need to remember for Plab 1 exam as a cause of delirium is infections, for example, UTI or pneumonia, metabolic derangements such as hyponatremia as the cause of delirium in older adults. Delirium is reversible if you treat the infections or the metabolic derangements, then the sign and symptoms can be reversed and the patient may get better. And the patient may get better. The only dementia which has visual hallucination is Lewy body dementia. In all other dementia, there is no visual hallucination. But delirium, in delirium, hallucinations and illusion is a common feature. So remember this point as well. That's how you can differentiate between delirium and dementia. The first point is that the onset of symptom will be acute, while in dementia, the onset of symptom will be chronic. And the other important point by which you can differentiate between these two is that in delirium there are usually hallucination and illusions, while in dementia, except Lewy body dementia, all other dementia do not have any features of hallucinations or illusions. So this ends our discussion about dementia and its causes and a little discussion about delirium. I hope it's clear to everyone up to this point. You have 1 minute if anyone want to ask any question. Otherwise, I will start the next topic.
Can I take the screenshot of that tremors, please?
Yes, sure.
And the psychogenic, please. You scroll it up. Thank you.
Take a screenshot of this slide as well.
Thank you.
And this one as well.
Yeah, done. Thank you.
So now we are going to discuss some condition which can lead to muscle weakness. Different condition which can lead to muscle weakness, including Guillain-Barre syndrome, Mastenia Gravis, Lambert-Eaton syndrome, a motor neuron disease. These are the 4 conditions which can lead to muscle weaknesses. We are going to discuss some important differentiating point, how to differentiate between these 4 types of or causes of muscle weakness, what investigation and what treatment can be done in all these conditions. So the first condition that we are going to discuss that can lead to muscle weakness is Guillain-Barre syndrome. What is Guillain-Barre syndrome? Guillain-Barre syndrome is basically autoimmune destruction of the myelin sheath of the peripheral nervous system. So the myelin sheath of peripheral nervous system is destroyed by antibodies that usually formed after an upper respiratory tract infection or gastroenteritis. So if someone presents to you with muscle weakness that develops after a history of upper respiratory tract infection or gastroenteritis, then you will suspect Guillain-Barre syndrome. So a person presenting to you with muscle weakness that he has developed after upper respiratory tract infection or gastroenteritis, then it is most likely Guillain-Barre syndrome. In Guillain-Barre syndrome, the weakness usually starts from the lower limb, and the weakness starts from the lower limb and then it ascends through trunk, chest, upper limb, and face and neck and respiratory muscles are involved as well. So initially there will be weakness that will start in the lower limb and then it will ascend upward in the thorax or in the chest. It will affect respiratory muscle. It will cause the paralysis of respiratory muscle. So intubation may be required if respiratory muscles are involved. And also in face, the muscles of swallowing can also be involved, which will result in dysphagia. The facial muscle will also be involved, which will result in dysarthria. So all the muscles of the body can be involved in Guillain-Barre syndrome, starting from the lower limb and ascending upward in the thorax or in the face and neck, etc. Also, the reflexes will be reduced because Guillain-Barre syndrome is a lower motor neuron lesion. So there will be reduced reflexes. Also, there will be sensory loss and urinary retention as well. So in short summary, someone present to you with weakness that started from the lower limb and then he developed dysphagia, dysarthria, and respiratory failure. On examination, there is sensory loss and reduced reflexes as well. You will suspect Guillain-Barre syndrome. Initial investigation is in acute setting or during the attack is lumbar puncture. What will lumbar puncture show in case of Guillain-Barre syndrome? In lumbar puncture, you will see an increase in the CSF protein, but white cell count will not be elevated. This is called albuminocytologic dissociation. Protein is increased, but white cells are not increased. So, if in the exam they ask you about the investigation of choice in acute setting or during the attack, it will be lumbar puncture. And the gold standard investigation for the diagnosis of Guillain-Barre syndrome is nerve conduction studies. So nerve conduction study is the gold standard, and lumbar puncture is an investigation or initial investigation during an acute attack, which will show an increase in the CSF protein. The management of Guillain-Barre syndrome include plasma exchange because the antibodies that has formed after upper respiratory tract infection or gastroenteritis, they are causing the problem. So we can use plasma exchange as the treatment for Guillain-Barre syndrome. Plasma exchange is a procedure in which the patient blood is passed through a machine and the plasma which contain antibodies is filtered and excreted out from the body. Intravenous immunoglobulins can also be tried, which will bind with the antibodies and prevent them from destroying the or demyelinating the nerve fibers. And the third one is if respiratory muscles are involved, then respiratory support can also be used in the treatment. A short summary of Guillain-Barre syndrome is that symmetrical ascending muscle paralysis, symmetrical ascending motor loss plus sensory loss after respiratory tract infection or gastroenteritis is most likely Guillain-Barre syndrome. The next one is Mastenia gravis. Is it clear, everyone? Is there any question? So the next topic which can cause muscle weakness is Mastenia gravis. And the basic abnormality in the Mastenia gravis is that autoantibodies are formed against the acetylcholine receptors that are present at the neuromuscular junction. So the structure of neuromuscular junction is very important. There is a presynaptic membrane, then there is a synapses, synaptic cleft, and there is a postsynaptic membrane. When action potential arrives at the presynaptic nerve terminals, acetylcholine is released, which bind with the acetylcholine receptors that are present on the postsynaptic membrane, which result in the opening of voltage-gated sodium channel and an action potential is generated, which leads to muscle contraction. But in Mastenia gravis, autoantibodies are found against these acetylcholine receptors, which are present on the postsynaptic membrane. So these acetylcholine receptors are occupied by these antibodies. So acetylcholine does not combine with these receptors. So that's why Mastenia gravis can lead to muscle weakness as well.
Sorry, can you say that again, please, about the acetylcholine action?
Uh, for acetylcholine action, you need to understand the structure of neuromuscular junction, the junction between a nerve and a muscle. So there is a presynaptic membrane of nerve terminal from which acetylcholine is released, and then this released acetylcholine bind with the acetylcholine receptors that are present on postsynaptic membrane, muscle membrane. When it binds with the postsynaptic acetylcholine receptors, voltage gated sodium channels are opened, which leads to the entry of sodium inside the membrane, and an action potential is generated, which leads to the contraction of the skeletal muscles. In Mastenia gravis, antibodies against acetylcholine receptors are formed. These antibodies occupy the acetylcholine receptors and does not allow acetylcholine to bind with these receptors. So no action potential is generated, and it leads to muscle weakness. For Plab 1, remember that the classic presentation of Mastenia gravis will be like a patient with muscle fatigue plus D symptoms. So a patient who present to you with muscle fatigue or muscle weakness plus D symptoms such as a drooping of eyelids, diplopia, dysphonia, dysphagia. So muscle fatigue or muscle weakness with these symptoms such as drooping of eyelid, diplopia, dysphonia, and dysphagia. With positive autoimmune panel or positive acetylcholinesterase antibodies, the diagnosis is most likely Mastenia gravis. Now, the thing that you need to remember about Mastenia gravis is that its presentation can be similar to Guillain-Barre syndrome, but in Guillain-Barre syndrome, there will be a history of upper RTI, upper respiratory tract infection or gastroenteritis, and in Guillain-Barre syndrome, there was sensory loss plus reduced reflexes. Sensory loss and reduced reflexes. While in Mastenia gravis, reflexes are usually normal. There are no reduced reflexes. The reflexes, deep tendon reflexes in Mastenia gravis are normal. This point is important to remember. And another feature of Mastenia gravis is that the weakness or the muscle weakness is worsened with exercise or with activity. Why the weakness in Mastenia gravis is worsened with exercise or activity, or the weakness is worse at evening or at evening time? So a patient present to you with muscle weakness that gets worse with exercise or that is severe in the evening, the diagnosis will most likely be Mastenia gravis. Why the muscle weakness worsen with exercise? Because with exercise or at the end of the day or in the evening, all the acetylcholine that is stored in the presynaptic nerve terminal is consumed, and the quantity of acetylcholine is very less in the evening or after continuous use. So that's why as there is less acetylcholine in the nerve terminals after exercise or in the evening. That's why the weakness in Mastenia gravis gets worsened with activity. So these two important points are important to remember to differentiate Mastenia gravis from other conditions which can cause muscle weakness. Mastenia gravis is sometimes associated with thymoma. Thymoma is basically a tumor of thymus gland. Thymus gland is basically involved in the production of antibodies. So in Mastenia gravis, usually the autoantibodies that are formed, they are formed in the thymus. So thymectomy is sometime in is an treatment choice for the treatment of Mastenia gravis. Now, these were some differentiating point on the basis of signs and symptoms and history. Now, how you can differentiate on the basis of findings in the investigation? The first finding is that serum anti-acetylcholine receptor antibodies will be positive. So a patient with muscle weakness plus day symptoms and anti-acetylcholine receptor antibodies are positive. The diagnosis is most likely Mastenia gravis. Other investigation that you can order is that thymus CT or MRI scan to see if there's a thymoma, and also repetitive nerve stimulation test. What will be the finding of repetitive nerve stimulation test? As I already told you that in Mastenia gravis, the weakness worsen on repetitive action or repetitive use. So if you repeatedly stimulate nerve in Mastenia gravis, the weakness will get worsened. And the